He walks in the house, goes to toilet, he gets problem. He eats food, he gets problem. He walks 10 steps, he gets problem. So all these patients need additional therapy beyond drug therapy. So when we are talking of plain balloon angioplasty, the recurrence rate was 30%. When I came to a plain stent without any drug, 15%.
Okay.
And now with the newest stents, the recurrence rate has gone down to as low as 2 to 3%. Body always tries to take care of whatever is the problem in there.
You take care of your body will take care of you.
I have a patient who says, I want to roar like a lion. My treatment with only drug can never give you that quality. If your heart does not work for 2-3 minutes, like when the pulse goes to 240, the BP drops down, maybe you can die. And therefore you need to give a treatment what is known as DC shock.
Your heart is in constant motion. But have you ever wondered if surgery is your only option when something goes wrong? Hi, I'm Jagu and welcome to the Good Doctors Podcast by Zynova Shalby Hospital. In today's episode, we're joined by Dr. Bhaskar Shah, who's been at the forefront of heart care, shaping the way we treat and understand cardiac conditions. From pioneering minimally invasive procedures to exploring groundbreaking treatments like TAVR and AI-driven solutions. Today, we'll break down the tough choices around heart surgery, the latest alternatives, and what the future holds for cardiac care. Let's dive in. Doctor, welcome to the Good Doctors Podcast, and thank you for taking out the time. We're hoping over the next 40-45 minutes to mine you for all your experience and expertise that you bring to the table, and certainly in the doctor's case, literally to the table. We want to explore today in this episode alternatives to surgery, to cardiac surgery. But let me explore something before that. Why does one need surgery to begin with? Say, in the case of an emergency, how does one decide that a patient has had a heart attack, cardiac arrest? This is a likely candidate for surgery as compared to anything else.
Now, and when we want to talk about that, let us first understand what we are meaning by cardiac disease.
Yes.
Now, when we are talking of heart problems, the commonest disease, what we talk of, is also known as coronary artery disease,
Yes.
which is also known as ischemic heart disease. And let me explain exactly what it means. For example, look at this. This is heart, and this is exactly the size which is there,
Okay.
and it is lying over here. On the surface of the heart, there are what is shown in red color, vessels which are known as coronary artery.
Okay.
There are multiple of them, 3 major, one lying in the front, one right, and one in the back.
Got it.
These vessels perform the function of supplying blood to what we call muscles of the heart.
Okay.
These muscles form the wall, W-A-L-L, of the heart, and it has multiple muscles which perform the function of pumping.
Sure.
For it to pump well, it needs nutrition, which is supplied by this vessel. Their multiple branches ultimately go and supply blood to these muscles.
To the heart wall.
So in short, muscles lying in the wall of the heart do the function of pumping, which is in turn dependent on the blood supply, which is through this vessel lying on the surface of the heart, known as coronary arteries.
Okay.
These coronary arteries are normally clean and neat, and if for any reason they get blocked, as I could show you over here, these are clean vessels, and they can get blocked inside because of what we say medically atherosclerosis. In lay term, it means deposition of fat and cholesterol in the vessel because of multiple causes, which my previous speakers must have already told you.
The whole lifestyle thing or smoking, diet,
So
exercise.
absolutely.
Yes.
So it is multifactorial, as we would say, uncontrolled high blood pressure, uncontrolled diabetes, increased cholesterol levels, smoking, lifestyle, lack of sleep, and whatnot. So essentially, when I'm talking of a patient having coronary artery disease, I would mean that the vessels lying on the surface of the heart are blocked because of deposition of cholesterol because of multifactorial things.
Okay.
Now, when the supply to the muscles of the heart is reduced because of this blockage, we get typical symptoms, what is known as angina, which means the pain and discomfort in the heart because of diminished blood flow to the muscles of the heart.
Now, this can happen slowly or it can happen suddenly.
Yeah, absolutely. Both.
And in layman terms, for me, emergency is when it has happened suddenly.
Absolutely.
I had no idea. I was fine 5 minutes ago. Suddenly, I have a heart pain. And somebody with some sort of medical proficiency has said that this is probably a heart attack, cardiac arrest. And then they come to you. At this point, how do you decide in an emergency situation that this is a surgery candidate or this is not a surgery candidate?
Right. Now, first thing which we have to understand is that essentially the benefits of surgery or alternative therapies like angioplasty, which is very common, is maximum in the group who present acutely.
Okay.
Sudden onset of discomfort. There are
Okay.
different subset of patient, what is known as chronic coronary artery disease, where the block slowly and gradually increases and leads to fall. Whereas in a patient who presents acutely, there might be a block which may be 30, 40, 50%, maybe 70%. And suddenly you get what is known as rupture of plaque. And this block, which is 50, 60, suddenly within a span of few minutes become 100%.
Oh, so that is also sudden.
That is very sudden.
Okay.
So typically we get a history that a patient who was in the left for going to office, in his residence, he is fine. He walks down to station, climbs the bridge, and suddenly gets a chest pain.
Yeah.
And then he's uncomfortable, and within 10 minutes or 15 minutes, especially in patient, might go to the nearest possible nursing home because he starts getting excruciating discomfort in the pain, or maybe very uneasy, restless, etc., etc. So these are the patients which are typically known as acute onset, where a block, which was what we say subcritical, has suddenly within a span of few minutes become blown up to a full block.
Fair.
This patient, mind you, are the patient which gets maximum benefit with intervention. Opposed to a patient where the block has been gradually and progressively developing, the comparative benefits are less.
Okay. And gradually progressing, but diagnosed as such. As in, he knows that there is a blockage. He or she knows that there is a blockage. It could grow in time, but there are other alternate treatments to that.
Yeah.
In an emergency case where a blockage has gone from,
so once you get this acute episode, the first thing is to re-establish flow to the muscles of the heart as fast as possible.
Okay.
We say muscle is time.
Fair.
Moment this vessel gets blocked, and if it remains blocked for more than an hour or two, the muscles of the heart get damaged irreversibly.
Yes.
And therefore, as early as you can, establish the flow in this vessel, better is the prognosis.
And at that stage, surgery is the only option. There are no alternatives.
No, surgery is not the option.
Okay.
Because for surgery, you need to do a lot of preparations.
Yes.
And take him to the table, which may take multiple hours.
Okay.
And by then, the muscle might get damaged fully.
So that's not happening in 60 minutes.
Yeah. That is what is known as golden hour.
Yes.
So all what you need at that time, if you happen to be one of that unfortunate person to get into this discomfort, or you are a person who are close by to another guy who's getting in this problem, the first thing is to take him to the nearest possible center where you can start therapy immediately. If you are getting a center which is 5 minutes away, do not think of taking him to a place which is 2 hours away.
Got it. 60
B,
minutes is that golden hour
golden
crucial
period.
time.
Absolutely.
Yes.
However, lot of times we see people, when they get this discomfort, first they go back home. Then they call their general practitioner.
Yeah.
Then the general practitioner says, wait, I'll come. It takes time. He comes, he says, now we need a ECG.
Yes.
Now that the knowledge is percolated so well, most of the time is not wasted. But sometimes the patient insists, why not we call a consultant home and take an ECG and see?
Yeah.
And you spend that golden hour away and you reach hospital at a very late time.
Fair.
So please, for God's sake, moment you have a suspicion that you have a cardiac problem, go to the nearest possible center and get your electrocardiogram recorded with a cardiologist, and then he will take care of the problem later on.
Okay.
So first important message is, do not waste time when you have an acute episode of discomfort. Go to the nearest possible center as fast as possible. Now,
Doctor,
having said that, moment you go to that, the first thing the doctor is going to do is record an electrocardiogram,
Sure.
take your history, and come to a conclusion that this is an acute heart problem. And when I say acute heart problem, that means the block is nearly 95 to 100%.
Sure.
And luckily, in that, there is always an element of what we say soft block.
Okay.
Blocks we essentially divided into soft, which means soluble, and the hard, which is insoluble.
Okay.
And if you have a patient who has a soluble block, it's so easy to even give injectable therapy if you are in a remote place where you cannot have an access to a good, say maybe a tertiary care center.
Sure.
So now what is that? So moment you have diagnosed this, the first therapy which can be offered is medically known as thrombolysis. Okay. Thrombo means clot, lysis means dissolving. That means dissolving the clot with what is known as thrombolytic agent, or also what is known as clot-bustering agent.
But this is only if it is a soft block.
Every single patient who comes with acute pain would always have some element of soft block.
Okay. Okay.
Even if you can assume temporarily, it is 10% only. Even if you can remove 5% of that, the flow is established,
Yes.
irreversible damage to the heart is prevented, and now you can take the benefit of additional therapeutic measures to take care of the residual hard block, which is insoluble and cannot be treated with drug or medicines alone.
Okay.
So therefore, the first thing is you go to a center, diagnose. Now the next thing which comes in is this center capable of doing what is medically known as angioplasty?
Okay.
The typical term is known as PAMI, P-A-M-I.
Okay.
Primary angioplasty. In MI stands for myocardial infarction.
Okay.
Now this means doing angioplasty immediately within that golden hour, as fast as you can.
Sir, can you explain angioplasty to us?
Now angioplasty, again, as I can show you over here, this is a vessel which is totally normal. What you do in the patient where there is a block which is 100%,
Yes.
you take them into a lab, what is known as cardiac catheterization laboratory,
Okay.
with the help of very thin wires, what are known as guide wires. You go across the block. Having gone across the block, you can sometimes suck out the block,
Okay.
what is known as suction.
Okay.
Sometimes if it is not necessary, the clot is not too much, you just go inside, take a balloon, as you could see over here again. So there is a balloon. You open the balloon, what is medically known as inflate,
Okay.
at a higher pressure,
Okay.
which is normally measured in what is known as atmospheres.
Okay.
Like, for example, if a car tire, also the air when you are inflating in it is measured in atmospheres.
Atmospheric pressure,
In the
yes.
car, we explain to 20, 22. If you remember, when you go in the car, we say the front wheel 20, 22, 50, rear wheel 18, 16.
Yes.
So that is atmosphere. same high pressure of 18 to 20 atmosphere or sometimes even higher pressure we do. So what happens is the soft block is sucked out and the hard block is cracked.
Ah, okay.
And so the whole vessel is open.
At what
Now
point?
having done that, it's like a stone which has been hard
Yes,
and it gets cracked into multiple pieces.
sure.
Now if you look at those pieces, they're having all uneven surfaces.
Yes.
Some may be sharp, some may be round, some may be this. So now what you have done, a block which was reasonably smooth with small surface of erosion have been converted into a plaque, multiple small pieces of uneven surfaces.
This is its own risk.
Huh?
This is its own risk.
This is its own risk.
Okay.
So now what you have done, now when the surface is rough, the blood flowing through that gets stuck, it sticks to that place.
Okay.
It's like suppose there is a river and the water is flowing well. Suddenly you put one stone, all the dirt will get collected around that stone.
Yes.
Same way, when you crack this, you will get collection of all the blood particles around that which can reform a block.
Okay. How does one solve for this?
So now what is the solution to that? In good old days, we used to just balloon it and come back, say 1980s and 85s when we used to do that. And invariably, 1/3 of them would get blocked and would be called back in 2-3 hours, is again getting pain.
Wow. Okay.
So that was a big problem.
Sure.
Gradually, we came of innovation of what is known as stents. Now, stents are hollow tube which goes inside, and when you are getting in, it's like an umbrella which is closed. When you go on, it open up, and that sticks to the vessel wall, and therefore all that rough surfaces are now not coming directly in contact with the blood. Now the blood is coming in contact with the stent,
Got it.
and
Okay.
that whole particles are stuck to the wall.
Fair enough.
So that is what was the second innovation, stent.
Okay.
But again, here, the stent was a foreign body. People again got a reaction over there, and again for getting a clot, and the stent would get blocked. So all what was happening is collection of blood particles which are getting stuck inside. Then came the innovation of what is known as drug-eluting stent. In lay term, what it means, the stents were now internally coated
Sure.
with some drugs which were normally used for cancer.
I see. Okay.
What is cancer? It's collection of multiple cells where the drug goes and dissolves them.
Okay.
So now here you have a drug which is lining the stent. So after you put there, some clots will come and form there, and this coating will dissolve.
We'll dissolve the clot.
So that same
Okay.
process would go on. So when we are talking of plain balloon angioplasty, the recurrence rate was 30%.
Okay.
When I came to a plain stent without any drug, 15%.
Okay.
And now with the newest stents, what are known as drug-coated stent, and there are a lot of innovations on now what are known as third generation drug-eluting stents, the recurrence rate has gone down to as low as 2 to 3%.
Excellent. So 30 to 15 to now 2 to 3%
2%.
because of advancements of medical technology.
Absolutely.
So there's another thing I keep hearing about, especially for children, stem cell therapy. Now, invariably, there's a lot of research going on as far as stem cell therapy is concerned, not in just cardiac cases, but in a whole bunch of medical issues. How is stem cell therapy helping on the cardiac front?
So again, there's the results of stem cell therapy are reasonably promising in young children.
Okay.
Not so good so far in adults. They've been tried.
That's why I read about it, especially in terms of children.
In general.
It's more effective,
So yeah,
seemingly
so
in that
there
area.
where we use, there is a disease what is known as cardiomyopathy. What in again lay terms means cardio is heart, myo is muscle, pathy is disease.
Okay.
So disease of the muscles of the heart.
Got it.
Now what is that disease? The pumping power of the heart is less. There is sometimes significant irreversible damage or sometimes partial reversible damage. Now basically in cardiomyopathy, the pumping of the heart is less. And in this type of situation, what you do is you inject stem cells, either intra-arterial, what we say, or directly into the myocyte, that means into the muscles of the heart.
Okay.
And they can now start a new process of new cell formation in the heart.
I see.
So you get new cells which are more powerful, which are normal, and then therefore the pumping of the heart improves. So it is
Okay.
this one disease, what is known as cardiomyopathy, especially in children. Sometime when they have any other cancers in the body, they give drugs, chemotherapy. One of the problems with chemotherapy is cardiomyopathy.
I see.
Side effect of
It's
the
a side effect. Okay.
And there, this stem cell therapy is supposed to be very useful. There are some congenital heart problems, what is known as hypoplastic left heart syndrome, very complex term. All that you have to understand, friend, that is some disease from birth, which
Okay.
are complex diseases.
Okay.
There also this has been tried.
But this is now only in play, not from a blockage point of view, but
No,
from a
it is
heart
a-
muscle point of view,
Absolutely. There is
hardening
nothing to
or
do with
thicker.
these
Or,
attacks or anything. Nothing.
Okay.
Now, in adults,
Hmm.
when this vessel get blocked,
Hmm.
and assume that you have reached doctor not within that first 2 hours,
Hmm.
maybe 12 hours,
Hmm.
and you still have some muscles which are dead, some muscles which are alive.
Sure.
What you have to remember is that heart muscle and brain muscle, these are the two places where there is no power of regeneration.
A dead muscle is a dead muscle. It's not coming back. Okay.
You have a skin peeled off, new skin will form.
Sure.
You have part of liver chopped off, a new liver will come.
Hmm.
You have part of kidney chopped off, new kidney will form. But you have part of heart muscle gone, it's gone once for all.
Heart and brain. Yes. Okay.
So it is irreversible damage.
Understood.
And there is no power of regeneration.
Fair.
In this type of patient, suppose the pumping of the heart has significantly gone down because there was a delay in therapy and the muscle has got damaged.
Hmm.
Now, we are trying to instill this stem cell therapy to again form new muscles over there and improve the pumping. So it is not going to do anything to the blockage.
Okay.
The muscle which are damaged can be repaired. Or you can regeneration.
Which is a huge advancement,
Huge
if
advancement.
it
But
works
there,
on a high
it
percentage
has
level.
worked in multiple things.
Okay.
There are multiple things which you need to do. You need to know how much to inject, which type of stem cell to inject, how long to follow up, what are the therapies. So it is still not standardized. They have tried it. They've been successful. But sometimes suppose you want to make cell multiply and grow more. Suppose it starts growing much more than what you want. It becomes like a cancer.
Yes.
So you'll have to have a titrated dose, proper. So now studies as far as adults are concerned for heart means muscle therapy or stem cell therapy still are in experimental stage where I'm sure somewhere down the line you will have something more to offer.
Fair enough. Now, tell me, doctor, in all of this, where do pacemakers come in? At what point is a patient a likely candidate for a pacemaker?
Fine. So we are talking of again another disease.
Okay.
We decide heart, primarily we divide into two major disorders.
Okay.
One is what is known as vascular problem. That means this vessel getting blocked and not supplied. Commonest disorder, heart attacks as we would say.
Sure.
The second type of disturbance is what is known as conduction diseases. Like in our house, we have cables for light and we have got water line for water supply.
Sure.
Same way in heart, there are two systems.
This is an analogy I can understand. Okay.
So here you have a situation where blood supply is like water supply.
Sure.
Like electrical cables is like the conduction system of the heart.
Okay.
So there is a conduction system of the heart. And if there is a disease in that conduction system where the current is not flowing well, for example, again coming to the same analogy, suppose there is no current in the house. So what happens? There is a blackout in the house.
Sure.
What is the answer to that? You keep a generator.
Okay. Oh, I see where you're going.
So you
with
keep
this.
a
Okay.
generator which supplies electricity if the natural flow. Same way here, if this conduction system in the heart undergoes degeneration, it does not allow the current to flow as it is.
Okay.
Therefore, what would happen? The heart rate would go down. And when the heart rate goes down, it can even stop the heart.
Yes, absolutely. Yeah.
So there, the alternative therapy is known as pacemaker. So pacemaker is one therapy whenever the pulse rate is too low because of disease of the conduction system of the heart.
Okay.
And you have now various types of pacemaker. We may not, like there's what is known as single chamber, dual chamber, etc., etc. All those probably may not be of interest, but essentially, when the pulse rate is lower than normal, leading to inadequate supply of blood, symptom of inadequate supply will be, say, brain doesn't get supply, you get giddiness, blackout, unconsciousness, etc. So all those disorders can be treated by putting an external generator, like what you would see in the house. This is known as external pulse generator, where you have pulse generator lying outside, below the skin, and the wire from there goes into the heart, which will produce continuous current. So if your patient say, my pulse is wavering, sometimes it is normal, sometimes it is low. When it is normal, this pulse generator stops. It is only on demand. Whenever the pulse goes down, it starts working. It is so designed. Like we have in levels where we have a generator. Your normal electricity, the generators don't work. It stops automatically, it starts working. This is exactly the same mechanism.
What is the life cycle of a pacemaker, sir? I mean, is it a number of years or
on
usage,
an average, nowadays we have good generators which easily last for more than 10 years, sometimes 15 years.
Okay.
And at the end of that, the wire can remain. You need to just change the pulse generator, the battery.
Okay. That is not a complicated process.
It is a very simple procedure.
Okay.
Overall procedure of entire pacemaker also is simple. But of that, changing the battery is very simple.
Got it.
So this is one use of pacemaker. Similarly, sometimes people have diseases in the conduction system wherein the pulse becomes too fast.
Oh, that can happen. Okay.
200, 250.
Okay.
In that situation, one of the treatment is to deliver a shock.
Okay.
Now again, if your heart does not work for 2-3 minutes, like when the pulse goes to 240, the BP drops down, maybe you can die.
Yes.
And therefore, you need to give a treatment what is known as DC shock, which if you are lucky enough to get into an hospital in that span within few minutes, and someone delivers a shock, you'll survive.
This is what they call a defibrillator. Okay.
Now, same defibrillators are nowadays like for external CPR, on roadside problems. You get the same defibrillator available and shock.
Sure.
That is where you now train laymen and lay people and security guards, etc. about all these things. Now,
but they still have to be trained on how to use it.
Absolutely.
Sure. Okay.
Now we have devices which, when people who are prone to that, we can find out who are the people who have more chances. Very poor ventricle. What we say, the pumping of the heart is measured in a terminology, what is known as LVEF, left ventricular ejection fraction. In layterm, what it means, if suppose there is 100 ml of blood in the heart and it pumps like that, normally 60 ml of blood is ejected out.
I see.
40 remain inside. Another 60 will become 100. Again you pump 60 out. So normal pumping power is 60%.
Okay.
Or ejection fraction is 60%.
Which is what we want.
What is want.
Okay.
Now it is a range. So again, it should not stuck to that 60. It is plus or minus 7.
Okay.
So 53 to 67.
Got it.
Now if that pumping power goes down, say it becomes 20% because of irreversible damage. Now that heart has a high chances of going into this, what I told you, fast pulse rate, what is medically known as ventricular tachycardia and ventricular fibrillation.
Okay.
Less term, very fast pulse rate.
Okay.
Now imagine 1 minute, if the heart has to contract 240 times and relax 240 times. By the time it contracts, there is a time to relax. There is effectively no contraction.
But the average is usually about
60,
75.
Yeah.
Okay.
So that time, there is a time to come in up and down. So it is about 0.6 to 0.8 second per cycle.
Sure.
But say it is 240, 300. By the time it contracts, there is a time to relax. There is hardly any effective contraction.
Sure.
In that type of situation, as I told you, patient becomes unconscious. And delivering shock, the rhythm will go back to 70, 80 immediately.
Sure.
Now this, first time it happens, it's okay. But suppose there is a person who is prone to that. Who are that? Like people with poor pumping power of the heart.
Sure.
Normal pumping power of the heart, the chances of this happening is less than 1%.
Okay. So this poor
That means in
pumping
the normal
is your
people like me
LVEF.
and you who doesn't have an attack, no pumping problem, you still have that half 1% chance of getting into a problem.
Okay.
But a person where the pumping power is low, say 20%, the chance is 25%, 30%.
I see.
So they are highly prone. So if you have a patient whose pumping power is less, I would put in what is known as AICD, C, D. Automatic, implantable, C for cardiac, and D for defibrillator. So what I'm talking external defibrillator, now this is implanted into the body, and now that has inbuilt capacity to detect this fast pulse rate.
So it's not a constant. It's at some point it can realize that the system needs
Normal pulse, it doesn't do anything.
Okay.
Moment it becomes 240, it senses it. It now realizes, it say, oh, something is wrong.
Okay.
I need to act.
Okay.
It'll wait for 10-15 minutes. Sometimes the pulse will become normal on its own. Fine. If it doesn't happen in 10-15 seconds, it will deliver a shock.
Understood.
So it's a life-saving device for people with poor pumping power. So these are also known as pacemakers in lay term.
Fair enough.
So for fast pulse rate, slow pulse rate. Similarly, if the pumping is less, there is also another device known as CRT, cardiac resynchronization therapy, which improves the pumping of the heart by a specific mechanism. So pacemakers, as I said, there are three major types.
Sure.
A for slow pulse rate, B for fast pulse rate, and 3 for improving the pumping of the heart.
Fair enough. And this is something that a doctor decides on a very individual basis and things like that. I want to come back to what I'm discovering now seems to be a bit of a gold standard between angioplasty and a bypass. Grafts, it seems, is not just one type of graft. And is it a selection? Who decides? Does the doctor decide? Is it a cost issue? Are some grafts better than other grafts? How does that work?
Fine. So before we go into that, let me make for everyone's understanding, what do you mean by graft?
Fair enough. Yes.
When we are talking of these blocks which were lying on the surface of the heart, and when we do a bypass surgery, you put in new vessels. You do not do anything to the old vessels.
Okay.
You do a bypass. So
Okay.
just before the block and after the block, you insert a new material, what is known as graft.
Okay.
So there are special definite indications where you want surgery and angioplasty. At the moment, let us assume that based on the clinical picture, based on the age of the patient, type of block, multiple, small, 1, 2, 3, etc., there are definite criteria which we can discuss down the line if you want. But essentially assume temporarily, based on merits, it has been decided by the cardiologist, the surgeon, and sometimes we say heart care team, that bypass surgery is necessary for this patient. Now for that, you need to put in these grafts, so which are natural vessels which are lying in the body, which is used for this. What you would understand here first is coronary arteries is a high pressure system.
Okay.
There are something known as veins in the body, which is low pressure system.
Okay. There are waves in the body. You said waves in the body.
Veins.
Veins in the body. Yes. Okay.
Like this, when I'm talking here, these blue structures, what are known as
veins,
perform the function of bringing blood back to the heart.
Okay.
And artery performs the function of supplying heart from the heart to the entire body.
Got it.
Supply, artery. Venous back, veins.
Got it. Okay.
So you've got veins which are low pressure system. Artery, high pressure system.
Oh, I see. Okay.
The disease is in coronary artery.
Okay.
That means you have a high pressure circuit over there.
Sure.
Now, if you want to put in that something, if you put a high pressure system in a high pressure circuit, it will automatically last much longer.
Okay. Sure.
Suppose in the same high pressure circuit, I put a low pressure system.
There's an anomaly.
Because these vessels, they are low pressure system, that means they can bear the low pressure very well. Now we put in this circuit the veins, which are naturally formed by God for bearing low pressure. And now you are subjecting them to high pressure. This vein will not function as long as you want.
Sure.
Therefore, venous graft, when we use, the life of that graft average is 70 to 80. Now you may have a person where it may last for 20 years and the person where it may go down in 4 years.
Got it.
But in general, the life is lesser compared to arterial graft, because arterial graft are high pressure system in a high pressure circuit.
Understood. Okay.
So first important difference, venous graft, arterial graft. Low pressure system, high pressure system. Therefore, low pressure system will degenerate faster. This will last longer.
Also, the practical aspect of it is that if it's a venous graft, then at some point you've done the surgery now, you're going to, in your lifetime, most probably need it again.
Much more earlier than when the arterial graft is there.
Okay.
So now, therefore, the best thing would be what we say arterial grafting.
Okay.
And in that, if I can put all the blocks, suppose there are 4 blocks, and if I replace every single artery with an artery, it is modically known as total arterial revascularization.
Okay.
And that is always the best thing to do.
Okay.
There
But
are
this is
occasional
only-
situations.
Only if there are multiple blockages or...
A bypass is normally done for multiple blockages.
Okay.
Therefore,
Okay.
suppose some situations are there where we may not need multiple blocks,
Then a stent
and still
will
you do a surgery.
I see. Okay.
There is one situation known as left main. The artery, when it starts, the left system has one main vessel which divides into 2.
Sure.
If there is a disease in left main, and if the patient is surgically good candidate, surgery gives better result than angioplasty in that location.
Okay.
So left main is one place where probably surgery is better than angioplasty.
Even if it's a single blockage,
Yeah.
there it's worth it.
That is what.
Otherwise, you only
Otherwise,
do it
you
for
say
multiple
multiple blocks,
blockages. Okay.
surgery is better, more so in diabetics.
I see.
Diabetic, the recurrence rate in angioplasty is much higher
Yes.
compared to non-diabetics.
Yes.
So diabetics, multiple block, surgery.
Got it.
Left main, surgery. Another situation is if the pumping of the heart is less, say pumping is 30%, 20%, and multiple blocks, then again surgery.
Understood. Okay.
So basically 3 criteria: function of the heart, pumping,
Hmm.
number of blocks,
Hmm.
left main involved or not involved. Besides that, the nature of the blocks. Suppose the vessel is extremely curved, where I cannot pass a wire, where I cannot pass a stent, vessel is very, very hard, which I cannot break, then sometimes surgery becomes. Now, luckily, in angioplasty, we have got excellent system for breaking that hard blocks also. Like what we use, lithotripsy treatment, as we must have heard, for kidney stones,
Yes.
which are very hard. You deliver lithotripsy is a treatment where you flux. Now that same lithotripsy can be applied in heart, and you can, if the block is very hard also, you can crack it down and open it up.
Okay. But then what happens to the fragments?
They are converted to small fragments, which gets dissolved through the blood and then goes out into the urine.
Oh, okay. Similar to the kidney stone situation. Okay.
When you are doing an angioplasty, they get pressed, and some of them go in circulation. But when you have lithotripsy, they can break down and they'll go in
Got
circulation.
it. I want to look at another version of what one hears about when it comes to cardiac, minimally invasive. Now that sounds like it requires lesser recovery time, but what are we talking about in terms of success rates when we say minimally invasive surgeries? And I'm assuming there are different types.
So fine. So let us understand, what do you mean by minimally invasive surgery? Essentially, typical bypass, you take a big cut in the center, what is known as sternal cut,
Yes.
open the chest, do the surgery and come out.
And at this point, like you have to crack the rib cage and things
Yeah,
like that. Okay.
the entire sternum, mid-sternal
Sure.
bone, then you
Okay.
and then you do the surgery and come out. And then whether it is total arterial, venous, is immaterial. This is a
Okay.
approach road.
Okay.
Nowadays, people do what is known as, in the ribs over here, they cut. And then with minimal exposure, they go and do the surgery.
Okay.
Through that, they may put instruments, like nowadays we have robots.
Hmm.
You can put a robot which will go at every places and do surgery and come out. Similarly, when you do valve surgery, there are people who will do from here. So the incision is smaller, it is not mid-sternal, therefore expected recovery will be faster, will be back home faster, maybe the pain will be lesser, etc. etc. But
Let me
again,
ask
it
you
needs a
this.
specific skill.
As effective?
Now, if again, when you properly select a case, yes.
I see.
For example, again, I'll just give you an example. So it's very easy. Suppose there is a patient who has a block here, there is a block in the back also.
Okay.
When I opened and varied exposure, I can turn the heart like that and operate on it. I can turn it up till and operate on it. When you have a small incision, you can't do all that thing.
Sure.
So if your patient has a block which is in the back, it's not as easy
Sure.
as it is when you're doing an open heart. Again, over a period of time, The patient, when the doctor does it repeatedly and gets skill, they may be in a position to do that also. But as on today, if you have a block which is lying in the back of the heart, what is known as posterior wall, probably that minimal invasive may not be very effective.
So you make an interesting point about the minimally invasive, and you've explained it very well. And this is not something that a patient decides. It is done, it is medically decided by the doctor whether it is going to be effective or not.
Absolutely.
Okay.
So again, it is skill based.
Yes.
Availability of instruments. Suppose there is a person who is doing a surgery, he says, like, you can, but you need a robotic instrument.
Sure.
You need endoscopes.
Sure.
So again, availability of equipment, skill of the patient, and then definite proper indication. All those three things are necessary for deciding whether minimally invasive surgery can be done in a given patient or not.
Okay.
Commonly used for what? As I told you, robotic surgery for bypass. Extremely in infancy stage as far as we are concerned in India. Gradually picking up in the Western countries.
Got it.
But valve surgeries now quite often are done with this minimally. So whether it is, you know, in the heart there are 4 valves. And any valve, when it is not functioning to some extent, there are indications for replacing the valve or repairing the valve. All those things are now often done with this compared, like bypass, minimally invasive surgery, not very common. Valve surgery, fairly common.
So is that what they call TAVR?
TAVR is again little different.
Okay.
TAVR stands for, T stands for trans aortic valve replacement.
Okay.
That means there is one valve in the body, what is known as aortic valve,
Sure.
which often, especially in old age, becomes sclerotic, degenerative, doesn't function well.
Okay.
And there are definite indications where we say you need to replace that valve.
Got it.
And if you have to replace that valve, then nowadays we have a very effective therapy known as TAVR.
What was happening before this?
Before
heart?
this, the ideal thing was to open the chest, open the heart, and put in an artificial valve.
Okay.
So
now
it was a big surgery which would last for 4-5 hours,
Okay.
etc., etc.
Now we're not doing any cutting.
Now we can, not in every patient.
Okay.
Definitely elderly patient, about 65 years of age, you can do a therapy in a patient where the diagnosis is known as aortic stenosis. That means the valve is narrowed down. The orifice of the valve is extremely narrow. Normal valve area when the valve opens is in the range of 4 square centimeter.
Okay.
When it goes down below 1 square centimeter,
Oh.
then you need to replace the valve.
Sure.
And now multiple trials across the world have shown that this can be very easily done totally non-operatively. And that is what is known as, like how you do an angioplasty, put in a wire from the groin. The procedure lasts for about an hour, hour and a half. And you can replace, or you can do aortic valve treatment that way. What you do essentially is you bring in a valve, artificial valve. The original valve which is there is pressed, and this valve stands in that.
I see. Okay.
So you don't remove the old valve.
Okay.
It is pressed across the wall. So this is very easily possible. Extremely, only limitation as on today is the cost. The valve of the cost is a limitation. But now with the use being very frequent, the cost is coming down. And I'm sure somewhere down the line, it will be the treatment of choice for every patient, especially elderly above 65, where this can be done. In younger patients, often still we do not have adequate data for that.
Okay.
But probably now trials are going on where maybe the age group might go down. Elderly patient, where one surgery and maybe you're done for another 15-20 years. Elderly patient, they are not very active, so the valve which you now put does not degenerate very fast.
Got it. Okay.
They are often having contraindication for surgery. They may
Fair
have lung problem, they may have liver problem. So this subset is very well studied and accepted as a standard treatment above 65.
Okay.
Below that, there are situations, there are places where you still do this, but then you need to discuss a lot of points for and against before you do that.
Fair enough. I want to move this ahead to the future of cardiac care. everybody talks about AI. AI is now entering the cardiac care, cardiac surgery field in a substantially large way. How is it moving along? Is it from a preventive point of view? Is it from a detection point of view? Does it help during surgeries? Where is AI coming into your field?
The major role for sure, detection
Okay.
and investigations.
Okay.
For example, now we know that with huge data available in AI and machine learning and AI and all that thing, diagnosis as a preventive, in the sense suspicion of a coronary artery disease in a given patient, is much higher when you use AI, because AI have now a large data which are accumulated, and therefore what we say integration of data
Got it.
is very important. As I told you, that cardiac disorders are multiple causes: diabetes, blood pressure, smoking, bad lifestyle, lack of sleep, etc., etc. Similarly, there are multiple investigations: plain cardiogram, stress test, stress echo, thallium scan, MRI, whatnot. Now, when you have so many things to be integrated and then come to a firm conclusion, AI is far more superior than human mind.
Doctor, as we close this very insightful conversation, I do want to ask you, there are so many myths surrounding heart disease, heart surgeries. Is there any one or two of them that you would like to address?
Yeah, I would say that heart disease and heart surgery is full of myths.
Fair.
There is no
Okay.
doubt, unlimited myths. But some of them which are very important to know from practical point of view. A is, so many times the disease is asymptomatic for years together. You may have multiple blocks in the vessel, and yet you may have no symptom. You may be walking around, running around, doing everything, and then suddenly one fine day you land into problems. And then the family asks, suddenly, "ये तो बहुत दिन से है. This has developed over a period of," but क्यों पता नहीं चला? Answer is clear.
Yeah.
It is a silent disease.
It wouldn't be sudden if you were tested.
Yeah.
Okay.
So it is there for years, but symptoms come later.
Got it.
So first thing you have to remember is cardiac disease and the risk factor which causes cardiac disease: high blood pressure, diabetes, cholesterol. They are also asymptomatic. You may have high cholesterol and no symptoms. You have diabetes and no symptoms. You have high pressure and no disease. So disease is asymptomatic. The risk factors are asymptomatic. And the only way to know is by doing a check. And therefore, my sincere advice to every single person is, even if you don't have any symptoms, if you have a strong family history or otherwise, make sure that you at least get blood sugar checked, blood pressure checked, cholesterol checked. And if you're finding anything abnormal in that, along with strong family history, smoking, lack of sleep, tobacco chewing, etc., then go further ahead and do investigations to find out silent coronary artery disease.
Fair enough. You need to help yourself first.
But
Fair.
yes, vice versa, it should not be overdone either. If you say there is no pressure, no diabetes, no cholesterol, no smoking, sound sleeper, then just don't unnecessarily go on doing test after test after test.
No, valid point. Thank you for showing us the middle ground. Thank you for opening our eyes to stuff that is happening in the field that we probably didn't even know about, and for explaining it so well to us. Dr. Shah, it was a pleasure to have you on. Thank you for taking out the time and this very insightful conversation that we've had.
It was really very interesting to talk with you, and thanks a lot for this.
Our pleasure. Thank you. Heart care is changing fast, and knowing the options could be the difference between surgery and something much less invasive. A huge thank you to Dr. Bhaskar Shah for sharing his decades of expertise and helping us explore the innovative treatments that are redefining heart health. If this episode made you think differently about your heart, share it with someone who could benefit. Watch the full episode on YouTube, Spotify, or your favorite podcast platform. And remember, taking care of your heart starts with knowledge. See you in the next episode. In the heart of Mumbai stands a name trusted by thousands. Over 1 lakh heart procedures, 200 plus years of combined experience. From diagnosis to recovery, your heart gets complete care under one roof. Because when it comes to your heart, experience isn't optional, it's everything. Zynova Shalby Hospitals. Experience you can trust, care that you deserve.